Which is the fibula? Long one or the long one? Okay. So basically the fibula is a very long bone. It is homologous with which bone? Ulna. But the ulna is present medial or lateral side? Medial. And fibula? Lateral. Because what happens during our development in embryology, what we have studied, that in case of foot, the flexor region becomes extensor. But I mean the front of the foot is the extensor region actually. And the back side of the foot is known as the flexor, which is opposite in case of our arm. Similarly, this is the, what do you mean by dorsum? Usually we think that dorsum means posterior, but in case of our foot, the dorsum is the upper flat part. Okay. Similarly, see if our limbs move like this and goes like this is the dorsum of the hand. So in case of foot, this is our dorsum, the part that is present above. And the lowermost part, that is the sole of our foot, is known as the plantar region. Okay. Now, fibula is the lateral long bone of the leg, homologous with the ulna of the upper limb. Now, how to determine the site? So, basically, superiorly, this is the fibula. So, superiorly, there will be the styloid process present where? Posterior-laterally. So, posterior and then lateral side, we will be having the styloid process. Okay. So, this is the styloid process. This is the styloid process. Okay. This one is the styloid process. See, it is present posterior and laterally. Okay. So superiorly, this is the styloid process. The lateral malleolus will be obviously in the lateral side. This is the lateral malleolus. Okay. So these are the main two differentiating point. And another point is actually this part. That is, the anterior part will be having a sharp anterior as well as an interosseous border. The fibula is actually a very tough bone. In what aspect? Because you need to have some imagination to understand the fibula, because the borders will be in close proximity. So you need to understand that, okay, this is the medial surface, this is the lateral surface. Okay. I will show you. So superiorly head with the styloid process, laterally lateral malleolus, anteriorly triangular articular facet on the lateral malleolus, that is for the talus actually. So we will come to these structures. So the fibula is mainly divided into three parts: upper end, shaft and lower end. So the upper end will be having obviously head. The upper end is also known as head, and just below the upper end we have the neck, this constricted part, similarly as the radius and ulna. Then the upper end have a posterior and laterally there is the styloid process. In front and medial to styloid process has articulation for tibia. So if this is the styloid process, anteriorly, front means anterior, and medial, this should be the facet for tibia. So, this is bone of which side? Right side or left side? Right side. How are you telling?
So, styloid process is posteriorly and
laterally?
laterally.
Posteriorly and as well as laterally. And lateral malleolus?
It is laterally.
Laterally. If I do it like this, then so it is coming, this side is laterally, so basically when
styloid process is coming anteriorly.
Styloid process is coming anteriorly. So the styloid process should be posterior-laterally placed. Okay, fine. So this is the right fibula. And one important thing, if you are holding a bone, if it is a right-sided bone, you should always pick it with the right hand. If it is a left-sided bone, pick it with the left hand. If it is present horizontally, vertically, then you need to keep it like this. You cannot show fibula like this. Okay. So it has an upper end, lower end as well as a shaft. So the upper end is actually having the head as well as the styloid process and the neck. The lower end is actually flat from side to side. It has the lateral malleolus as well as the facet for triangular facet for, we will see all the structures. Triangular facet for talus. Talus is bone of foot. Okay. So talus having its facet. You understand facet na? So talus has its facet and forms the ankle joint. And superiorly the tibia and the fibula forms the superior tibiofibular joint, and inferiorly there is inferior tibiofibular joint. Okay, and the shaft has 3 borders and 3 surfaces. This is actually the tough part. So now coming to this picture, see the shaft. First of all, see the shaft. So this is the shaft. See, there is the anterior border and there is an interosseous border. Okay, and posteriorly there is another posterior border. This is the posterior border. See, the anterior border and the interosseous border is in close proximity, almost 2 to 3 millimeter gap is there. But if you come to the lower end, you will see that the anterior border going downwards and almost reaching up to the superior part of the lateral malleolus. But the interosseous border coming downwards and going medially, almost medially. So in this way you can differentiate the anterior border and the interosseous border. This is the interosseous border. How to see in this bone? If this is the right sided bone, see, this is the anterior border coming like this, going downward. Just this is the lateral malleolus, just above the lateral malleolus, this is the anterior border, and just adjacent to this there is interosseous border. This one is the interosseous border. One thing to ensure that whether you know the basic thing, what is a border and surface. If I take this register, which is the borders, these are the borders. So this becomes the surface. Okay. So see. So this is the anterior border and this is the interosseous border. Automatically, if there are 2 borders, in between there will be a surface. So this surface, if I hold the bone like this, the anterior border is facing, anteriorly, and the interosseous border is almost medially, facing medially. So the surface they are forming, this is the medial surface. This surface you cannot see from anterior. If you move the bone like this, then you can appreciate the medial surface. Similarly, posteriorly, there is the posterior border. This is the posterior border. Okay, this is the posterior border. So the posterior border also similarly forming one surface between the anterior and the posterior border. Okay, that is the lateral surface. Okay, see, this anterior border and interosseous border is forming a surface which is known as the medial surface. This is the medial surface, and this anterior border and posterior border forming a surface which is known as the lateral surface. And there is another surface which is known as the posterior surface, which is present just behind the bone. Okay, this posterior surface again gets divided by a medial crest. This is like a small, long hilly type structure, elevation like structure. This is known as the medial crest. This is not a border actually, just a crest. So this is dividing the posterior surface, which is the largest surface of the fibula, into medial part and lateral part. Okay, you have understood the bone now?
Yes, sir.
All the borders, because fibula is actually tough. So I am just repeating again. If I hold the bone like this, you are seeing this anterior border coming like this. Okay, then just adjacent to this, this is the interosseous border. So for your for you, like you can go approach like this. This is the anterior border, this is the interosseous border, and just posterior to this, this is the posterior border. Okay, posterior border. So this is the right sided fibula. And the surfaces, this is the medial surface, this is the lateral surface, and just posteriorly this is the posterior surface, having again lateral part and medial part, divided by medial crest. This is the crest, this is not border, this is crest. This is the border of posterior surface. Okay. So the lower end is flat, forms lateral malleolus. Medial side of the malleolus bears a triangular articular surface for the talus, and the deep malleolar fossa present behind the articular surface. So what it is saying, that this is the lateral malleolus. Here we are having a facet for the talus, and just behind this there is another fossa, which is deep malleolar fossa. That's it. Now coming to the borders, I have already described the borders. Having anterior border which is sharp, begins below the anterior aspect of the head. Near its lower end, it turns laterally and joins the apex of the triangular area above the lateral malleolus. So basically just above the lateral malleolus. Posterior border, upper end lies in line with the styloid process. Lower end reaches the medial part of the posterior surface of the lateral malleolus. So this is the lateral malleolus, just behind the posterior border ends. See? It is ending like this. This is the posterior border. Now coming to the interosseous border, it lies near anterior border, merges with the upper part of the rough area above the talar facet of the lateral malleolus. So basically just above the triangular facet for talus, the anterior border, inserts. Not insert actually, extends. Now coming to the surfaces, I have already described the lateral, medial and posterior surface. Now these are the attachments of muscles. So basically we are having 9 muscles, 1 only inserts and all the other 8 muscles having their origin from fibula. Okay, so we have the insertion for biceps femoris and all the other muscles have their origin from fibula. So this long red muscle is the extensor digitorum longus. It arises from the medial surface. Then this small muscle, this is the peroneus tertius. This also originates from the medial surface, and another muscle is the extensor hallucis longus, this green one, which also originates from here. Now coming to the medial surface, you can see here, this is the lateral surface. See, the yellow one is the lateral surface from where the peroneus longus originates, then peroneus brevis and extensor digitorum longus, I have already told in the anterior part. Now tibialis posterior arises from the medial part of the posterior surface. So this is the posterior surface, the back side of the bone. From its medial part, that is, this is the medial crest, and from medially this surface, the tibialis posterior originates. And the flexor hallucis longus originates from the lateral part of the posterior surface. Then from the superior part, the soleus originates from lateral part of posterior surface superiorly. Then flexor hallucis longus originates from the lateral part of the posterior surface, and then here is the posterior border, and then peroneus brevis we have talked here. Then laterally we can see the extent of the peroneus brevis muscle, this small muscle. It has a flap which goes like this, and there are certain important structure we will see later on. Now these are the muscle attachments. So the biceps femoris inserts in the head of the fibula. Extensor digitorum longus originates from the upper 3/4 of the medial surface. Peroneus tertius, medial surface means this part. Okay, so upper 3/4. If I divide it into 4 parts, this leaving this lower 1/4, the upper 3/4 whole is extensor digitorum longus. Then peroneus tertius, just below the extensor digitorum longus, it originates. Extensor hallucis longus originates from the medial 2/4 of the medial surface, medial to the origin of extensor digitorum longus. So if the origin of extensor digitorum longus is like this, just medially another muscle is there which is the extensor hallucis longus. Peroneus, if a name comes with peroneus, always think that this is the lateral part. Peroneus longus, peroneus brevis, only the peroneus tertius is placed actually laterally here, but we consider it as anterior compartment or the medial surface muscle. So peroneus always comes in the lateral part. You will see in the dissection also in the upcoming weeks. Peroneus longus originates from the upper 2/3 of the lateral surface and lateral aspect of the head of the fibula. Peroneus brevis, it's a small muscle. It originates from the lower 2/3 of the lateral surface. Then comes tibialis posterior, which originates from upper 2/3 of medial part. Don't chew chewing gum in class. Okay, tibialis posterior originates from the upper 2/3 of medial part of posterior surface. Throw it. Throw the chewing gum. So peroneus brevis originates from the lower 2/3 of the lateral surface. Tibialis posterior originates from the upper 2/3 of medial part of posterior surface. Soleus originates from the posterior aspect of the head and from upper 1/4 of the lateral part of the posterior surface. It is a very important muscle actually, soleus. You will see, if you see the posterior compartment of the leg, there is gastrocnemius muscle, and if we remove the gastrocnemius muscle, we will see this long muscle which is the soleus. Then comes flexor hallucis longus. Obviously it will be in the posterior part. How?
Sir, because in the lower limb we consider posterior part as flexor.
Flexor. Okay. And hallucis means it will be inserted in hallux.
Yes, sir.
Hallux means foot, great toe. Great toe. And longus means long muscle. Okay. So it originates from the lower 2/3 of the lateral part of the posterior surface. Now these are certain other attachments, you just need to go through this. This is the capsule of the superior tibiofibular joint. That is the point where the tibia and the fibula makes the joint. There is a capsule which marks that margin of the tibial facet.
That facet, tibio.
Like there is a facet for here you will find the, see, this is the styloid process. So here it is the facet for tibia. So tibia will attach here. If tibia attaches here, like a capsule will develop, not develop, like a capsule will be present which will prevent friction between the two bones. Okay, so that it is saying that part only. See this thing, capsule of superior tibiofibular joint. Then fibular collateral ligament arises from is present in the lateral aspect of the head. Interosseous membrane in the interosseous border. So basically the interosseous border you have seen, there comes the interosseous membrane which is present in between the fibula and the tibia. Similarly in the upper hand also you have seen interosseous membrane. In the upper hand also you have seen that there is a space in between the interosseous membrane for the passage of vessels. Okay. Similarly in the lower part also, in the interosseous membrane, superiorly around 1/3 or 1/4 you can say, there is a space through which the tibial vessels enter the anterior compartment or the extensor compartment. Then comes the interosseous ligament of the inferior tibiofibular joint. So basically in the inferior region where the interosseous border ends, there is another, this part. See, in the lower part, this is the interosseous border. Anterior border, interosseous border, it is going downwards. Where it reaches, there is actually the point where tibia attaches. The whole tibia attaches like this. Okay, so there is another ligament for prevention of friction. Then superior extensor, posterior tibiofibular and posterior talofibular ligaments. So what is talofibular ligament? Fibula, they join together, and surrounding that there are certain ligaments. Similarly tibiofibular also is present. So it is present in the malleolar fossa. Where is the malleolar fossa? Just behind the facet for the talus. Okay, deep malleolar fossa. Then superior extensor retinaculum of the ankle. So it is present in the anterior border of the triangular area above the lateral malleolus. So we have seen extensor retinaculum in hand also. Here extensor retinaculum is present. Similarly extensor retinaculum will be anteriorly in the foot. Superior peroneal retinaculum, posterior margin of the lateral malleolus. So just behind the lateral malleolus there will be the peroneal retinaculum. Now fibular relations. So there is common peroneal nerve which winds around the neck of the fibula. Okay, lateral aspect of the neck of the fibula. What happens in case of fracture of the neck of the fibula, which is very common? Okay, so basically dorsiflexion is controlled by the peroneal nerve. The peroneal nerve, also known as the common peroneal nerve, is divided into superficial and deep peroneal nerve. Okay, so basically if this common peroneal nerve, also sometimes known as the common fibular nerve, if it gets affected due to fracture of the neck of the fibula, then dorsiflexion will not occur. So basically this is our foot, this is dorsiflexion, this is our sole. If we do like this, this is plantar flexion. You are understanding now?
Yes, sir.
Through the chewing gum out. So this is the dorsiflexion and this is plantar flexion. Okay, so if the common fibular nerve or the common peroneal nerve gets disturbed, so the patient will have a foot drop. So he or she cannot stand properly. If he tries to stand on his toes or on her toes, then it will fall apart. Like how to say, if this is the sole, this is the leg, we usually walk like this, no? We walk like this, he or she will have like this. Okay, the foot gets dropped. Okay. The plantar flexion obviously will get exaggerated and dorsiflexion will not occur. Okay. Then tendons of peroneus longus and peroneus brevis pass just behind the lateral malleolus. See here. See. Just behind the lateral, this is the posterior aspect of the bone. So just behind the lateral malleolus, we are having the tendons of peroneus longus and peroneus brevis. Now, ossification. So basically, the first center, that is the primary center, appears in the shaft. Okay. So it appears in the shaft, and it gets completed in the 8th fetal week. Okay. The secondary center first appears in the upper end. No, first appears in the lower end, then appears in the upper end. So in the lower end, it first appears in the first year and fuses in 15 to 17 years. Okay. And secondary center in the upper end appears in the 3rd and 4th year, fuses with the shaft between 17 and 19 years. Now there is a catch that in case of most of the long bones, if the secondary center appears first or earlier, then it also completes earlier. But in case of fibula, it is opposite. See, in most long bones, the secondary center that appears first is the last to fuse, but the fibula is an exception in that the center which appears first for the lower end is also the first to fuse. So I told opposite actually, is the last to fuse, but in case of fibula, it is first to fuse. See, secondary center, lower end, first year it appears and it fuses like earlier. Okay, and upper end it appears also later on and also gets fused, late. Okay. Now coming to clinical anatomy. So basically palpation of common peroneal nerve, we can easily palpate the nerve in the lateral part of our leg, just lateral to the patella, we can palpate it. Then fracture neck of fibula and foot drop I have discussed. Bone grafts. So in case of any grafting purpose, if a bone gets broken, if we need some graft, we take it from fibula. Okay. Then Pott's fracture is actually a combination fracture where the medial malleolus of tibia gets affected, and in case of foot, the deltoid ligament gets affected. Okay, and some portion of the lower end of the fibula also gets affected. So in total, it becomes a comminuted fracture. Okay, so that's all in fibula. Now coming to patella. So patella is a very short topic. Patella is also known as kneecap. So we are born with our own kneecap. We usually use kneecap in case of cricket. So you have seen kneecaps? Yes. Boys have seen, I know, but girls? Okay. So kneecaps, so this is our kneecap. Basically what is different in case of patella, this is known as the apex. And the apex is pointed downwards. Usually apex is at top, but in case of patella, the apex is pointed downwards. And this is the base. And there are two borders and surfaces also too. We will talk about that. So the patella is the largest sesamoid bone. What is the sesamoid bone?
No variation.
Huh?
No, it is not tender, and there is no periosseous.
Originates from tendon and has no periosteum. Okay. What is the function of a sesamoid bone? Why it develops at the first place? Because so that the muscle can easily glide over the bone. Okay. So the sesamoid bone is developed from the tendons of submuscles which have embedded in them small bones that help them to glide over bony surfaces. Such bones are called sesamoid bones. Patella develops from the tendon of quadriceps femoris. Similarly, we have what bone? Pisiform bone. Developed from the tendon of
Flexor, digitorum, longus.
flexor carpi ulnaris. flexor carpi ulnaris. There are other sesamoid bones also in our body. You go through that. Okay. So side determination, the apex is directed downwards. There is an anterior surface and a posterior surface. Simple. So borders also two, superior border and inferior border. So anterior surface is rough and non-articular. See, you can easily identify the anterior surface. It is rough, okay, and non-articular. Non-articular means it articulates with no bone, okay. Then comes the posterior surface divided into medial and lateral side, and the lateral side will be big, okay. See, the lateral surface will be big, and there is a medial surface which is small. So the posterior articular surface is divided into lateral large and medial small areas by a vertical ridge. See, this is the anterior surface, this is the apex, and this is the base. This is the posterior surface. Posterior surface is divided by a vertical ridge into a medial, lateral part, which is the larger part, then the medial part. Okay. Now the patella is a disc-shaped bone, triangular in outline. It has two surfaces, anterior and posterior, separated by three borders: superior, medial, lateral. Okay. This is the superior border. This is the medial border. This is the lateral border. Okay. Now the anterior surface is rough and can be felt through the overlying skin. Posterior surface, upper part is articular. It articulates with the patellar surface on the anterior aspect of the condyles of the femur. This means that, so the femur has how many condyles? Medial and lateral condyle. So the medial condyle articulates with the medial part of the posterior surface of the patella. Okay. And the lateral condyle articulates with the lateral part of the posterior surface of the patella. Okay. You are getting?
Yes, sir.
Okay. So the posterior surface has a larger lateral part and a smaller medial part separated by a ridge. The most medial part of the articular area may be recognizable as a separate area. This part articulates with the medial condyle of the femur only in extreme flexion of the knee joint. See, this thing. This is the medial part. This is the immediate medial part. Then comes an extreme medial part. So basically in extreme flexion of the knee joint, flexion to you know na straight leg. So in extreme flexion, this part gets involved. And it can be easily understood also. In this bone though we cannot know, but you can see, this is the extreme medial part. This part is the medial surface, this is the extreme medial surface. So the lower part of the posterior surface is non-articular. It is rough for attachment of the ligamentum patellae. So this part, this is non-articular. This part is articular. Obviously, because here the femur will articulate, femur condyles. Okay. So the superior border has attachment for rectus femoris muscle and vastus intermedius. Here, first the rectus femoris comes, then the vastus intermedius comes. Then the medial margin has attachment for medial patellar retinaculum. So here the medial patellar retinaculum attaches. These are not muscle, these are structures. Okay. Laterally we are having the lateral patellar retinaculum, and apex we are having the ligamentum patellae. So only 5 structures: ligamentum patellae, medial patellar retinaculum, lateral patellar retinaculum, superiorly rectus femoris, and vastus intermedius. All these muscles will be taught to you in the dissection hall. So basically ossification center, the patella ossifies from several centers that appear between the 3rd and the 6th years of life. The centers soon fuse with one another. So due to this reason also, in some person you will see that the patella is usually broken. Okay, it is congenital, like from birth it is broken. It is known as bipartite patella. So bipartite patella happens because the patella has many ossification centers. So if they do not ossify in a proper manner, 2 or 3 multiple bones appear. Usually 2 bones appear. Okay, that is not a fracture, that is a congenital condition. The patella will be separated. If there is a real fracture of patella, what will happen?
Knee joint dislocation.
That will to occur, but there will be a transverse fracture of the patella. So the quadriceps femoris is a very strong muscle. It will pull the upper part. So the upper part of this upper part of patella will be pulled out. Okay. So transverse patellar fracture, where in this way the fracture occurs. So the quadriceps femoris muscle attaches here, so it will just pull out the bone and it will go above, and this lower part will be at the knee point.
Sir, what about that two upper muscles that are also present in the?
That will also pull. That will also pull. But this is the, I mean, this is present in the tendon of quadriceps femoris muscle, na. So that is a very strong muscle. See, quadriceps. Triceps means 3 head. Quadriceps means 4 head. Biceps means 2 head. Okay. So housemaid's knee means prepatellar bursitis. So in case of housemaid, you will see that they kneel down on the ground and usually sweep the floor. So due to this reason, what happens? The prepatellar bursa. What is bursa? Fluid filled sac. Fluid filled sac. Okay. So it prevents friction between the bones. So the bursa gets inflamed due to repeated kneeling down and sweeping the floors, and due to this region it becomes prepatellar bursitis. This is known as housemaid's knee. You will see that the knee gets swollen, and clergyman's knee is subcutaneous infrapatellar bursitis. So just, I mean, inferior to the prepatellar region, there is infrapatellar region. Here is the infrapatellar region. So there is also a bursa which gets inflamed in case of clergyman's knee. What is clergyman? No, that is clerical. Clergyman's knee means in some religion, usually people kneel down on the ground and then pray to God. Okay, so in those people it happens, the subcutaneous infrapatellar bursitis. That's all.